Welcome everybody to the second patient-centred care webinar for ISQA Knowledge. It's a pleasure to be convening today. The topic we are focusing on is improving patient experience and the lessons from Disney and other organisations. And we're very pleased to have Bill Shannon with us, and I'll introduce Bill in a minute. I would also encourage you to join ISQA Knowledge if you haven't done that already. It's a vibrant community. There's many different parts to the web portal, and it's a great place for having conversations with others interested in safety and quality. So please become part of the community. I'm very pleased to say that we have today over 80 registrants from all around the world. We've got people from the USA, from Japan, from Yemen, from Australia, Canada, Brazil, Ireland, the Philippines, Italy, Guatemala, just to name a few. So thanks everybody for joining us in your respective time zones. Just some technical things to start with. If you would like to go to the top of your screen and click on the icon that says participants, and also click on the icon that says chat, you'll be able to join us and to post some chats throughout the webinar. We really invite you to post questions, and you can do that by sending your chat to panelists, and then we'll all be able to see the comments that you're making. The topic for today is a very interesting one. It's quite topical at the moment. Improving patient care experience is in the foremost of many executives' minds. There are many drivers happening around the world at the moment to focus on this particular area of quality. One of those, particularly in the US, is public reporting and reimbursement being linked to patient experience, and that's certainly getting some attention. In other parts of the world, there are the introduction of standards and accreditation that links into improving those partnerships with consumers and patients, and ultimately improving the patient experience. So we have a very topical area, and we have a gentleman of great expertise who's going to be talking with us today. I'd like to introduce Bill Shannon. Bill, it's a pleasure to have you. You're a visiting scholar at Duke University. You were the Senior Vice President and Chief Wisdom Officer, which is a title is amazing, at DaVita, which is a healthcare service provider in the US. As Executive Director, formerly for Service Improvement at Duke University School of Medicine and Health Systems, and 21 years with the Walt Disney Company, where you helped to conceive and establish the Disney Institute, which brought lessons from Disney about the business behind the magic to other organisations. So it's a real privilege to have you with us, Bill. And I'd like to pose a number of questions throughout the session. I'm hoping that's okay, Bill. But I'm going to hand over to you, and I wondered if you might be able to start by talking to us a little bit about why experience is an important component of healthcare quality. We know that it's one of the areas that the Institute of Medicine in the US has designated for a number of decades now as a domain, an important domain of quality. So I wondered if you could talk to us a bit about that, and perhaps some of the lessons that you've learned around the importance of experience from places like Disney. Thanks, Bill.
You're welcome. Good morning, good afternoon, good evening to everybody. It's a pleasure to be with you, Karen, and everybody else who's joined. It's an honor to be here. I think in terms of the big picture, what we've learned about the experience is so much of what people understand is really how they're treated as human beings.
You might have to talk up a bit, Bill.
What I would like to say is, can you hear me better now?
Yeah, you might just have to be a bit louder. Thank you.
Okay, I'm screaming, but that's all right. What I was saying was, in reality, it is the experience that surrounds clinical care delivery that people really do grasp and understand. So what we've learned here and in other places, and Disney is such a great example, of how to treat their guests, no pun intended, that the experience really surrounds what goes on clinically. You see, it is such a great mystery to most patients what goes on clinically. They assume that technology is calibrated properly. They assume that the diagnostics are correct. They assume that that lab result is accurate. What they know and think more and more about is the way they're treated as people. And so when I think of this big picture, what I think a lot about is the greatest now and the best in the field, they don't separate the clinical experience from the actual experience that surrounds the delivery of care. You know, more and more patients now come informed thanks to the internet. More and more hospitals have accountability built in for leaders around their patient satisfaction scores. And so, you know, it's unusual. It's not unusual now to drive down one of our highways and see hospitals, for-profit and not-for-profit, public and private, to be advertising wait times at their emergency departments to try to get people to come into the door. So this patient experience has even become a very competitive part of healthcare in America.
Thanks, Bill. I guess one of the criticisms that might be raised in this discussion is that in the States you perhaps have a history of customer service, and in many places there is an imperative to increase that market share. Whereas I think in some countries the public systems are really just trying to cope, you know, and are inundated, and in fact they don't necessarily want more patients. Can you comment on that, you know, whether this approach in terms of focusing on patient experience is relevant to other places that don't have that history of customer focus?
Yes, I can. I've done some work via Disney within the last year with several countries in Latin America. And what they are beginning to learn and beginning to think about is if someone has a better experience overall, does that mean they're not going to need a readmission? Does that mean that they're going to leave physical therapy quicker and recover faster if the experience around that is more strong, and that people feel more engaged in their care? So although we probably don't have the reputation of the friendliness that your country has, Karen, we certainly do in some places in America. But we really believe here that whether it's public or private, there's a huge upside to treating people well in the experience and in the interaction with staff. You know, one of the things that I've taught a lot is that the people who are paid the least are with patients the most. And we need to understand that as leaders, and so do those employees. This is why Disney is so strong in this area, because Disney knows, like other great companies know, that it's the relationship between what Disney calls cast members and the Disney customer. That's the big reason people return. That's the big reason people are so attached to the brand. And so I recognize and realize that in some locations it's not a complete match to what we do in America. But it's hard to argue that treating people with dignity and respect and treating employees the same way can lead to a better healthcare experience. I firmly believe that in my heart.
It's interesting that when you look at the evidence in this area, there is, you know, particularly in the last 5 years, there's quite a lot of evidence emerging linking that improved care experience with the improved clinical outcomes, improved business metrics, as you've mentioned, such as length of stay and readmissions. and we'll talk a little bit later about the relationship with staff. But you touched on something that I think again has been coming through as a potentially new model, which is relationship-based care, and not only the relationship between patients and healthcare professionals, but also the relationships between healthcare professionals, needing to understand that this is a service that's very much based on communication as much as it is on the technical aspects of care. I wondered if we might talk a little bit, Bill, about the importance of leadership. I was reading a great paper in the last week from Cleveland, from Cleveland Clinic by Chris Nagel about healing leadership and the importance of leadership. And I think we've seen that. I certainly saw that in the work that I did in the US in this area. If the leaders are not committed to improving the patient experience, it's a really hard task. So I wondered if you could comment a little bit about that importance of executive leadership, and also a little bit about the importance of senior clinical leaders who can spread that message throughout the organisation, help to set the tone.
I'd be happy to. There's no question that where hospitals and health systems have been most successful, their senior leaders are in fact very supportive and very engaged. And that is such a key component of even learning from Disney. I know later on we have a slide, if you want to jump to the slide that talks about the role of the leader. There's some key points there to make. This one that you've got here is really about making sure that leaders are held accountable and in fact engaged in supporting this process. You know, there are lots of organizations now that literally weigh patient satisfaction and that patient experience at the same level that they weigh clinical quality metrics and the bottom line of financial or operational metrics. Those organizations have realized that engaging their staff is another key part of that. See, if you ask a staff member to be a certain way, but leaders behave differently, then it's very, very hard to have an organization move forward in the direction that you'd like. You know, we learned at Disney back in the 90s that it's that relationship between the leaders and their employees, their cast members, that in fact is what drives that relationship between the guest and that cast member. So when I think about leaders, it has to be a big part of holding oneself accountable, hiring the right people, looking for attitude versus aptitude, being relentless in your training, and as you say, communication, and thinking about those things are very, very, very important. And you're absolutely right. If you're in an organization where the leaders get it, including physicians and clinical leaders, where they understand that this is the right thing to do, then you're going to make great strides with all the metrics that you've talked about. No question.
I wondered if we might just go back one slide. You had some quotes there that people might be interested in seeing. And whilst that's up, I was just thinking one of the differences that I noticed between the executives in the States in health services, and particularly in Australia when I was in the States for a while, was I looked at the length of tenure of some of the executives. And I found it quite interesting that we have a much higher turnover in particularly in the public sector in Australia of the executive leadership, particularly at the chief executive level, whereas some of the leading organisations that I saw who were improving their patient experience in leaps and bounds their chief executive stayed for an average of about 7 to 8 years. That's a big difference, I think, and perhaps other people in other countries experience the same thing. It's hard to get a long-term vision in place when you have that changing leadership. I wondered if you could comment on that. It was just an interesting difference I noticed.
I think a big part of that is, you know, some people sort of have that idea that the grass is always greener, and maybe that's just not true. I'm surprised that the number is that high. What you'll see here is someone moving to a bigger title or someone moving to a bigger institution, rather than, you know, I've been forced out, or, you know, things haven't worked out well for me. The other thing that you'll probably find a big part of great companies, great organizations in America, is they're really focused on promoting from within.
Right.
So you may find that as the Disney company, for example, and in the parks and resorts, well over 80% of their management and above are promoted from within the company.
Yeah. And Bill, taking those strategies, for example, from Disney and translating them to the healthcare sector, obviously you must have used your experience in the work you did with Duke University, with the medical school and with the health services there in terms of service improvement. Maybe you could highlight some practical examples that worked in that setting, and it'd be good to hear about how the senior team was supported and built.
Okay, if we can back up one slide, that would be helpful to the audience.
Backwards?
There you go.
That would be great.
One of the things that we brought to Duke that is still there today, and this was almost 11 years ago now, so way ahead of the game in a lot of thinking, as you'd expect from a great academic medical center like where you were up in Boston. The key things were having a set of standards and behaviors that were across the board. So in other words, we had here's an example where I have scripting, or an example of how metrics led to tactics. One of the things we knew is that we had people asking lots of questions of the caregivers as they left the room, or ringing the call button a lot with questions. So one of the things we did was ask the nurse managers to round every day, just to check in on everyone. And then we came up with one key, it was called Keywords for Key Moments. And for example, we asked people before we left the room, is there anything else I can do for you? I have the time. And most people said no, thank you. But those who did were able to get their questions answered quickly, or their request answered quickly, and complaints went down, and patient satisfaction scores went up, and our clinicians spent more time being clinicians. And another thing we learned from Disney that is in that third bullet under script service guidelines, and that is an engaged and empowered staff. See, if someone asks someone from dietary, can you get me a blanket? Very often you get, no, that's not my job. But we encouraged, and great organizations encourage their staff to handle those requests so that we're efficient and we're effective, but people are comfortable. I got my question answered, and someone took care of my needs. And these are the kinds of things that we took directly from Disney, standards of behavior and little nuances like that really matter. You know, Karen, I don't know if anybody's ever done this math, but it's interesting to find out how many people actually interact with a patient on an inpatient unit if they're there for 3 or 4 days. The number gets really high really fast. And what Disney is really good at is saying all of those moments are opportunities. And you can create great moments, or you can misstep. Because at the end of the day, or at the end of a hospital stay, people leave and they have this collective impression of the organization based on all of those small, short interactions. Disney's masterful at orchestrating that.
It's a very good point. And I think one of the misconceptions is that the sorts of things that you've just talked about actually take time rather than save time. And perhaps that they're not my role, as you said. They're somebody else's role, or making sure that the patient experience is good is something that we leave to the nurses. They're the kind of comments that I think you hear in the services, but we need a mind shift, as you've suggested, towards the fact that every intersection with the patient is impactful and is also an opportunity. And one of the models that we're promoting here through the work that I do in Australia is around patient-based care rather than patient-centred, which is more about everybody has an impact on the patient, and how do we optimise each of those opportunities. I think your comments around standards of behaviour are really important, and sometimes, again, I think that tone is set by the leadership. And I wondered, just considering what people remember when they come away from care. I had a discussion with a patient from an Australian hospital recently who actually was a retired nurse, had had a long experience in the healthcare system herself as a professional, came in to be treated for pneumonia, and told me her story afterwards. She really wanted to share her story. And she said that, Karen, I couldn't fault the technical care. The technical care was brilliant. However, she said at the end of it, I felt like I'd been treated like a lump of clay, and nobody really listened to me, and the experience was terrible. And so I find it very interesting when you get comments like that from somebody who has worked in the system, who really knows the system, and when they themselves are treated, I guess the shoe's a bit on the other foot. Do you have much experience in talking to healthcare professionals about walking in the patient's shoes, getting that experience from a different perspective?
Well, one of the greatest jobs I had at Duke that I miss dearly now that I'm out on my own a little bit and working with more not-for-profits was I taught the fourth-year med students in their capstone course. And these are very bright young people. They've picked their residencies and their fellowships, and they're heading out. And all I really had to do was sort of give them some basic fundamentals of thinking about customer service and turn them loose. And they would come back in a week and they have those exact kind of stories. They would say, I will never treat a nurse that way. Or he had his hand on the door while he was saying, is there anything else I can help you with? Or he stood up and as soon as he sat down, it was much more comfortable. And so I just kept telling them, yes, don't do that. Or yes, do that. And it was a remarkable thing because their eyes were so open after following their mentors around for 3 years, and how their own impact was going to be so powerful. And I also think that when you think about that story that you were told, we remember stories much more than we remember facts and figures. That's just kind of how human beings are. So here's a little piece of math. I think this is a Harvard study. You may have seen it. One dissatisfied customer will tell 9 other people, and each of them will tell 7 more. So now you have 63 people. And what Harvard said was about 25% were going to be impacted by what they heard. In other words, make a decision. And so now you have 16. So that one person that could tell people I was a lump of clay, 16 other people that the hospital will never see, will never know, are going to be affected by what she told you and she would tell others. Think about how many people now are listening to us and they're saying, I wonder what hospital Karen is talking about.
I'm not revealing. I think your math there is very interesting, and that's word of mouth. But I guess one of the other ways that people get to hear about patient experience now is through the internet, is through social media. There's a range of different ways that people are expressing their views about the experience that they've had with healthcare services. Just in the last month or so in Australia, we've seen a website launched called Patient Opinion Australia, which is modelled on a UK site. And I know you have Angie's List and a whole range of other things where people are actually talking about their experiences out there in the social media, and it has a much greater reach than the 1 in 9 ratio.
And you have to remember also, the younger a patient is, the more they're going to rely on social media for their decision making. And they're also used to getting their information quickly. So someone can leave and write a blog, or they can put a comment on a website, and before you know it, members of the media are looking at it, and you end up in a whole different, it's almost a service recovery situation, because people are venting, people are using it. And then, of course, organizations are using them too, to inform patients, to market to patients. I can go on the Duke website as a patient, and I can see my records, I can see my appointments, I can find out a great deal just about my own relationship with the organization.
Yeah, and I think some of the interesting ways in which these sites can be used, for example, on Patient Opinion, they are actually feeding that information back to the service and then giving the service the opportunity to talk about how they're going to improve that experience. I just wanted to mention to everybody that we have a poll up. We are asking people, does your health service regard patient experience as a key component of care? So let us know about your own service, your organisation that you're linked to, and how it values this area in comparison to other components of quality. We also have a question that's come through on the chat from Anne Axum. Anne's asking, Bill, and this relates to supporting staff and really building staff capacity. She asks, is scripting, could scripting be used to train staff in a way that it doesn't sound insincere and didactic? Is there a way of giving people support so that you can have a business model that everybody's using, singing from the same hymn book, but not necessarily using plasticky sounding words?
I think you can. If there may be places where you want to say exactly the same thing every single day. To know how crazy my brain works, listen to this. I can take you back to 1975 and I can say what I did at Disneyland. Attention Dumbo pilots, prepare for takeoff. To make Dumbo fly.
You've been programmed, Bill.
Keep your seatbelt fastened at all times. A way to look at scripting is using guidelines. In other words, if you want someone to say thank you, or if you want someone to say, do you have any questions for me, you can do that in not a didactic or a very deliberate way where you must do this every time. As long as people feel that they're being cared for, and as long as people can be themselves, we would be all for that. There are times where you can be on the telephone and there are certain things that you would want people to say. I've got on the slide that talks about engagement and partnering. If we want to jump to that slide, I've got some examples of keywords for key moments. people love to get the gift of time and information. So a way to script someone who's checking someone in to say, typically our patients are going to be here about an hour and a half. Then that sets a tone and some guidelines for the whole experience. Anything else that you might want to add, you can. But I think it's a powerful, powerful tool to present those guidelines. And here's why, in one word: consistency. So everyone knows that they're being treated consistently because of the words that are being used. So that's my answer. I think it's a very good tool.
I guess, Bill, one of the other parts of the importance of supporting staff and building capacity is that there is some evidence that there's a relationship between happy staff and happy patients, and that, you know, supporting your workforce really impacts on the experience of your patients. I know from the data in New South Wales, in the state that I'm in Australia, that when you look at the patient experience surveys from hospitals, that the way in which they perceive teamwork amongst the clinicians is one of the key drivers for a good experience, but it's equally a driver for a very poor experience. So we know that there's a relationship there, there's evidence of a link. And when I think about places that I've spent time with, for example, Medical College of Georgia in Atlanta, Georgia, they had a really fascinating history of going back about 20 years where they started to focus around the patient experience in terms of their care delivery. And they had initially, I think, something like an 8% vacancy rate for staff, and quite a high turnover of staff and absenteeism. And when they embarked on this journey, they saw a clear improvement in their position vacancy rate for staff, which dropped down to 0. And when I was there a few years ago, they had a waiting list of about 300 people that wanted to work with them as healthcare professionals. So, I mean, that was an amazing turnaround. I'm wondering if you can comment a bit about that relationship. You've mentioned it briefly, but do you think that health services really are attuned to this evidence, and how are they using that to support the work environment?
Well, one of the things that we sort of know inherently, but we really have to talk about it out loud, is places that have high turnover, lots of vacancies, unhappy employee satisfaction, those places, healthcare or otherwise, those places have a lousier bottom line. They don't operate as effectively. People don't recommend them in the marketplace. And again, the relationship with leaders to those frontline employees, that really matters a lot. So what the Georgia College did was take a look at, okay, we're not doing really well in creating a culture or an organization that is a welcoming one, a supportive one, one that people will want to mesh with and meld with. And so when you go back and think about it, we know that engaged employees who feel like they're part of the care team, who feel like their jobs matter, no matter what their role is, and if they work in a place where their ideas are welcome, that they feel, you know, what I've always taught is, if you want to know what's going on and you want to fix something that doesn't work, ask the people who do the work every day. They're the ones that take it home with them. They're the ones that talk to them about it. So organizations here, another thing I learned at Disney is everywhere we work, there's a culture. Disney's and other great organizations like Georgia College of Medicine and Duke and Partners and the other ones that you know about, and even small rural hospitals that adopt these things, what they know in their heart and soul is that it's literally the behaviors and the interaction of those leaders with staff that drive everything else. See, every place has a culture. You can either have a culture by design or a culture by default. And I think we all know that we'd rather have a culture by design. And you can't design a culture without an interaction and a strong relationship with employees. It just can't be done.
And one of the things that you mentioned just then that I think is a crucial part of that is having a learning organisation culture. So really wanting to have staff contribute to that learning process as an organisation and to growth. And part of that, is almost a topic for another seminar, but is being open about mistakes and learning from those mistakes. I think that really makes a difference, and certainly in organisations that I've seen that I would consider leaders in improving patient care experience, they very much had that learning organisation ethos. Is that something that Disney had as well? Were they open about mistakes and how to learn from those issues?
And yes, in fact, Karen, there's a very simple continuous improvement cycle that would be very similar and actually probably much more simple than some of the ones that you've seen modeled in Australia and elsewhere. And the key to it is you have to engage the people who are actually doing the work every day. At DaVita, my last organization, we had one person on a small team step up and say, we really would like to have a 1.5 cc syringe created, because we were typically giving that dosage of one particular medication to dialysis patients. And the syringe companies weren't making that. And he took it upon himself with the team, can I make a call? Absolutely. Well, let's think about it. DaVita had at the time 25,000 patients getting injections every other day at 1,500 locations. What do you think the syringe company said when he asked?
Absolutely.
And so there you have a one person engaged who saved the company hundreds of thousands of dollars because they thought about it, and they were in an organization where ideas like that are welcome and appreciated. And that's all part of being a learning organization.
I guess one of the challenges is for services that feel like they have a command and control culture, to shift from that is a very hard thing to do. And I think we've already acknowledged the crucial role of leaders in setting that tone. But when you're in a workplace in a healthcare environment where you're used to being told what to do and used to having that culture of command and control, it must be quite hard to shift to one that empowers the frontline staff. Did you want to comment on that?
I think you have to make that commitment from leadership, but I also think that you have to start small if that's the right thing. You know, there's one floor at Duke Hospital that anything new that is going to start, that's the floor it starts on. And it's because there's a leader there who, when she speaks or she gives the thumbs up, everybody kind of goes, huh, that must be okay. Because she's okay. And so part of it is to pilot sometimes at a smaller scale. You and I have talked about this before, Karen. It's one of the ironies of healthcare that when physicians and clinicians, when they read something in a journal or a study is released or a new device is approved and hits the market, boy, we're quick to change. We're quick to want it. We got to have it. It'll make for better care. It'll be better for patients. And it's so ironic that when the things that surround all of that could use that same approach, darn, it just sometimes takes a little bit longer. So that's why I like to say, if you don't separate the clinical experience from involving everybody in the patient experience, then you're not going to do something like put a new process in place and not tell anybody, or wonder how a new procedure is going to impact nursing. You know, you have a collective group of people that drive toward the same goal, then you've got a chance to make progress. But command and control, there are places in healthcare that's needed. The surgeon runs that OR. That's the way it should be. But everything that surrounds that, making that experience better, or a place where ideas are welcome, that's where organizations can be really, really strong and can really make the shift that you're talking about.
I wonder, Bill, particularly in your experience and also being in an academic environment with Duke, I'm just wondering about your views about how much the way in which we teach at an undergraduate level, the healthcare professionals of the future, how much that impacts on the way in which these cultures occur within the services. Is there opportunity? I mean, I'm looking for it constantly in my work, trying to work with undergraduate medical students, trying to think about how I can infuse some of that knowledge and experience about the importance of patient care experience as a metric of quality into that undergraduate level. Is there any experience you've had from the US or from Duke in particular about really helping to support the workforce of the future?
I just so miss talking and teaching those fourth-year students. I taught it with a member from the Board of Visitors, an ER physician who was a Duke graduate. And I know they've continued that. Of course, the biggest change here is cutting down the number, as you know, cutting down the number of hours that residents, in fact, put in. And I think that's been a big change in America. I also think that our young physicians or potential physicians, despite being, including being very bright, I think that they're much more engaged in the rest of the things that go on around them. You know, thanks to the internet, they shop differently. They communicate differently. They typically get their information and want their information faster. So I think great organizations are leveraging the electronic age, so to speak. You know, enabling young physicians to understand that they can have a relationship at the bedside, but also have a relationship with patients through the internet, and be able to do, you know, to be conversational in that particular way. I also think that what we've seen and will continue to see more and more of with young physicians is they're consumers themselves. And so they're great, they're smart, they've been competitive to get in where they go to school, they've studied for their boards, but in doing all of that, they've been very exploratory. You know, they've tried to find out, get as much data together as they can before they apply, before they decide where they're going to go. That carries over really well for them as medical students. And clearly, when they go on to internship, residencies, fellowships, they're going to have a great understanding of that. And then I don't know if it's more compassion is coming or not, but you know, we have more women in medical school now here than we do men.
Are you going to say they're more compassionate? That's a topic for another day as well, Bill.
I just thought I'd throw that out just to see what you'd say. You're
trying to bait me there, I know. I guess one of the other things that is helpful, and you know, perhaps I've heard you do have this in the States, is really making communication skills an important part of recredentialing healthcare professionals. So there are some other levers that you've got. I wondered if we've just put up a question which is about staff and leaders and whether they should be held accountable for service behaviours within the healthcare. And a question from Alison saying, when we say accountable, how's that manifest? Did you want to comment on the accountability because I think that's done in varying degrees in different countries. How is an individual healthcare professional accountable for improving the patient experience overall, and how does the service hold its staff accountable in that way?
Well, two significant ways here. The first is that leaders, meaning managers, have patient satisfaction scores typically as part of their own evaluation and their own professional development, and it's typically sometimes tied to compensation. So it's a part. You know, from Harvard, they have their balanced scorecard. It's got 4 quadrants in it, and one of them is clinical, the other's financial or operational, the other's employee or staff satisfaction, and the fourth is patient satisfaction. So first of all, it starts again with leaders. When it comes to the front line or clinical staff or even dietary or housekeeping or other staff, that's where it becomes hardwired, is what we say, to HR processes. In other words, these are the standards that we expect, and people are trained in those standards. They're trained in the guidelines of how to do what they do, and they're taught that what they say and how they say it and how they behave, and in some cases they're taught to be proactive. If you see someone that's lost, go help them find their way. You know, there's an appointment they're going to be late to. One of your teammates may be waiting on them, or they need to find their loved one's room. Those kinds of things as part of training, and then as part of communication, but more importantly, as part of evaluation and structure, and how those are put as part of someone's expectations as an employee. You know, that's a big part of how you do it. So it works for leaders as well as frontline staff.
I think that's a really good point. There's another comment from Donna Davis on the chat, which is about, you know, in her own organisation, she feels that the patient experience is very important, but it doesn't necessarily flow through to all the frontline staff. And I guess two of the things that you've highlighted today is that importance of leadership in setting that culture and sending that message, and promoting that mission commitment throughout the organisation, but also now, as you've just commenting about accountability. So what is the responsibility of the individual healthcare worker and staff member of the service to ensure that they're aiming to improve that experience overall? So I guess those are probably two of the key components in making sure that that filters through the whole organisation and doesn't just stay as some mission set by the executive.
Yeah, and sometimes the opposite will be true. You know, managers will people will be trained, they'll be very friendly, they'll do precisely what you want them to do, they'll be accountable, and then they'll go like this. What about those guys? What about the people on the top floor? So both issues exist. It's when you've got accountability through an organization is when you have an opportunity to really make inroads into a more quality patient experience, no doubt about it.
Bill, I'm wondering if you might comment about how to address what we would call the naysayers, the people who might say, well, look, you know, that's all very nice and well, but actually it's just the fluffy stuff, and you know, we're really focused on the hard-edged clinical outcomes here and the bottom line, because that's the message that we're getting is important. We want to focus on our safety and quality, and the stuff you're just talking about is really nice, but not necessary.
Well, I put up I call this slide the doom and gloom slide. That's sort of one of our expressions for naysayers. You know, interestingly enough, you know, physicians and many other people that are in healthcare, they know good customer service when they see it, and they know it when they don't. In fact, some might say they're experts in knowing when they see it and know it when they don't. So my experience in working with folks and working with organizations is that we have to measure. You know, we have to find out what's important to our patients beyond the clinical care. And then we've got to be relentless about making sure that we continue to have that be a focus in our organization. I'm working with a group now. They did a tremendous job with a patient safety initiative. This is their next priority. And so what we're doing is literally following the same path. This is how we announced it. This is how we built it into evaluations. This is how we communicated it. This is how we trained everyone to understand it. So it's in a context that everyone understands. And that it seems to be, when you're consistent, it's something that the employees sort of get. Oh yeah, they're serious about this. And one of my favorite things to do with the naysayer is that third bullet. You know, someone who says, you know, this is not me. You know, this is somebody else's job. You know, the kind of people, when I teach employee orientation and how to do it, I always include the naysayers. You know, the kind of people that will say, you know, okay, you've gone to orientation and now you've met this person that you're going to work with. And they say, well, let me tell you how it really is. I've been here 25 years, 10 months, 12 minutes and 62 seconds, and it has stunk from day one. You know, there are those people. They have that dark cloud wherever they go. And what I've taught organizations to do is get those people and say, okay, you think it's really bad. What do you want to do about it? And sometimes there's a switch that goes on. At first you'll get, no, wait a minute. No, it's not, no, that's not me. Well, you know, it really is. And so sometimes you can, by just asking that question, you put people in a place where they may actually step up, but you also put them in a place where they're going to be that bottom bullet. Now you can start holding them accountable because you opened a door. You knew they were negative. You told them there's a change a-coming, and you've given them a chance to link in with it. And the last thing that I would say is, again, if you can start small and show that it really matters, and there are metrics that you can really share. In other words, because we did this, wait times are less, or because we did this, you can see patients more efficiently, or because we did this, physical therapy patients are not coming back. Their rehab is faster because of the attitude of the therapist. Wherever you can start, and then you just communicate the heck out of that and build it throughout the organization. You know, that's where getting the right people in the room and the right people at the table really matters. Because if you create that part of an organization, then the doom and gloomers, really, they've got numbers to look at. They've got things that prove it's viable. And when you do that, you're on your way. You really are.
Yeah, I think that's a very important message, you know, particularly to let people know about the benefits not only for patients but for themselves as staff working in an environment. For the bottom line for the organisation. I mean, if you look at the work of people like Ashish Jha in the US, there's a clear link between those improvements in the clinical metrics and the improvements in patient experience. So I guess one of the responses to naysayers or people who say, well, I leave that to the nurses because that's part of their role, is about, you know, how important this is for the organisation overall and how much it does impact on that bottom line. I guess the flip side of that is often the things that you can do, the things that you can do differently and can really impact on improving the patient experience are not always the expensive things, I think, as you've demonstrated today. In fact, I think many of the services I'm familiar with who I would consider leaders, the things that they've done are actually really quite inexpensive.
There's no question about that. One of them is to say thank you. You know, if someone steps in for another member of the care team, thank them on the spot. They're much more likely to repeat that behavior. Little small things really matter. Or just to say, you know, an organization made a change because someone suggested it. You got to thank them, and you got to share that throughout the organization, because momentum and being positive is very important. And you know, Karen, who wants to work at an unhappy place?
Indeed. I think we perhaps don't recognize enough that in healthcare that our staff do have discretionary effort, and whether they're using it or not is often about, you know, what they feel in terms of their value within the organisation. I'm fascinated by looking at Australia at some of the staff surveys for healthcare professionals, and it interests me that the ratings on discretionary effort are always fairly low. I don't think we've unleashed the potential of that effort, and part of that's about the culture that you create. We're closing we're heading towards closing this webinar, and there's been some great questions in the background. It's been wonderful to see people's contributions on the chat. We've tried to address most of those. We've had the poll running, 2 polls running indeed in the background, and James has just put up the results for the first one, and if I can see them, this does your health service value experience as a key component. Yes, I think the majority said yes. Some didn't answer, and I don't quite understand the technicalities of that, but it looks like most people said yes, it was an important component. The other question was about how should staff and leaders be held accountable for service behaviours in healthcare, and there's a resounding yes to that one. So we know from our participants that we're on the right track, and I think, Bill, today you've given some really good examples of how that accountability can be manifest. So that's wonderful. So, Bill, any closing comments from you?
It's been great to be with you as always, Karen. It's great to be I'm just so honored to have all of these other countries all over the world be able to participate with us in the ISQA, and the work you've done is just fantastic. Please keep it going. My email is on the screen. Anyone in one of the conference rooms with a group of people, anyone that's participated today, anyone that wants to reach out to me personally, I'm happy to begin any conversation, answer any question, and you know, any friend of yours is a friend of mine.
Thank you, Bill. That's really wonderful, and your experience is enormous, and we really value you sharing your thoughts with us today. So I'd like to draw the webinar to a close. Thank you all for joining us, and we hope that you will keep interacting with ISQA Knowledge, and indeed register. It's free to register, and there are many conversations that are taking place on ISQA Knowledge now, and we'd love to have your thoughts and your contributions. So thanks for joining us, and we'll see you next time. Thank you. Bye, Bill.
Bye-bye.